Hello and welcome to this talk about responding to death policies. I'm Deputy Director for Clinical Effectiveness at South Tees, the acute hospital provider based in Middlesbrough. I also work for the North East Quality Observatory Service, supporting trusts in our region to monitor and learn from deaths in hospital. I'm the Patient Safety Collaborative Programme Lead for the Academic Health Science Network, working on clinical topics like sepsis because of their importance to hospital mortality. I'm also a member of the Q Initiative. National guidance was published in March 2017, which sets out the new requirements for learning from deaths. By now, each trust should have appointed a non-executive and executive lead at board level to drive a review of all existing governance arrangements for deaths. This includes establishing a formal responding to deaths policy by the end of September 2017. The policy sets out the range of ways in which trusts will identify, report, investigate and learn from deaths in care. Trusts should begin publishing information about avoidable deaths by the end of December 2017 for deaths from April 2017. At South Tees, our Director of Quality and Performance has led the process in close collaboration with the Medical Director and our Clinical Lead for Mortality Review. It's important that a wide range of people are involved in developing the responding to deaths policy, as there are many aspects to it relevant to different settings, from acute to community settings. In my hospital trust, we've structured the policy around the three key opportunities to learn from the deaths, namely at the time of certification of all deaths, during case record review for selected deaths, and when a death is investigated. The North East and North Cumbria has had a regional mortality group for about 5 years. It started as an acute hospitals group, but now has representation from the region's mental health trust and the ambulance trust. We've shared our draft policies in order to try to take a consistent approach. This will particularly help as more cross-system case note reviews and investigations take place. The group has shared criteria for selecting patients for case record review and our draft policies. Whilst there are differences between the policies, we are able to select what will work in each of our organisations, knowing what others are doing and learning from each other's experiences to date. The group has also shared approaches to publishing information about avoidable deaths. The National Quality Board released a template for this, and some of the trusts in the North East have been testing the process for populating it. It's likely that at least some trusts will display data from before April 2017 because it makes the graphs more meaningful, particularly as the number of deaths judged to be preventable using the case record review method is small. I want to turn now to the issue of death certification, as this provides the first opportunity to respond to a death in care. Every death is followed by the writing of a medical certificate of cause of death. At the moment, the team providing care will complete the medical certificate, and another doctor, not involved in that care, will complete the second part of this process. National reform, including the introduction of medical examiners, is currently expected by 2019, and this will modernise this process. However, some trusts are already implementing change. At South Tees, we're developing a medical examiner service based on the national pilot work in Leicester and Sheffield. More information is available from the website developed in Leicester that you can see on the right here. We are in the process of appointing consultants to provide a 9 to 5 Monday to Friday service. In future, when a death occurs, the medical examiner's office will be informed. The medical examiner will speak to the team providing care, assess the care provided in the final days of life as recorded in the case notes, examine the body and complete a cremation form where appropriate. In addition to these duties, medical examiners will also contact the bereaved family to offer any explanation they would like about the death of their relative. The medical examiner will help ensure the correct cases are referred to the coroner and provide education and support to doctors that will improve the recording of cause of death. Experience elsewhere suggests that the service is greatly valued by families, giving them a chance to understand what has happened to their relative in a timely manner, but a little after the event and away from the clinical area. The pilots also showed that the quality of recording of cause of death improved, and that liaison with hospitals for coroners was easier. There is an opportunity in our hospital to co-locate the medical examiner with the bereavement service, and that will help families deal with many aspects of managing a relative's death. If at any stage the family, staff or case notes suggest a potential problem in care, they'll be able to instigate a case record review. The second opportunity to respond to a death is provided by case record review, which we hope in future will be prompted by any concerns raised around the time of certification, and also routinely for certain categories of deaths, such as those following a surgical procedure. As there's already a talk about how we approach case record reviews in the North East, I won't go into those details now. There are 2 short videos on the NECOS website that you can access. The third opportunity to respond to a death comes when there is reason, either from case record review or because a serious incident is reported, to investigate a death. The number of cases investigated in each trust is small, and again I won't cover this large topic here. I'll just note that the new Healthcare Investigation Branch, HSIB, is supporting the NHS to improve the way it investigates deaths, and there's more information about this on their website. In conclusion, it's clear the NHS is committed to learning from deaths, and all organisations will need to examine and improve the processes they have to respond to deaths. We can expect the approaches to evolve from the policies we have in place, starting from September 2017, in part as change occurs for specific groups like children. It's essential that the response to deaths from the NHS becomes more integrated between organisations that provide care. For example, we know that we could do much better to learn from deaths of patients with serious mental illnesses. Failings in helping families bereaved in that context was a big part of the drive for this work, and we'll need to work together to improve what we do. Thank you for listening.